General Hospital in Boston, USA, who is going to share with us his interesting data on an antibody-drug conjugate, SGN-CD33A, combined with hypomethylating therapy that induces high remission rates in elderly patients with acute myeloblastic leukemia. Dr. Fathi.
Thank you so much for the kind introduction. Good morning. I would like to first, there you go. I would like to first express my appreciation to the European Hematology Association, as well as the organizers of this press briefing program for allowing me to highlight on behalf of my co-investigators our upcoming presentation this afternoon. We will be presenting some data from an ongoing phase 1 trial evaluating SGN-CD33A, also known as vadestaximab-talarine, in combination with hypomethylating agents among older patients with acute myeloid leukemia. Acute myeloid leukemia, also known as AML, is a lethal disease of the bone marrow and blood. It is particularly difficult to treat, with generally poor outcomes for the majority of patients. This is particularly so for older patients, in whom traditional cytotoxic chemotherapy, which is conventional, is harder to administer because of compromised functional status and comorbidities. In recent years, there has been an emergence, however, of hypomethylating agents, azacitidine and decitabine, as options for more gentle forms of treatment that can be administered on the outpatient side in the clinic, and which can provide some transient responses, although rates of remission with these modalities of treatments ranges between 18% and 28%. The majority of leukemic cells in AML express a protein on their surface called CD33. Vadestaximab-talarine, which from this point on I'll be referring to as 33A, is a highly potent antibody-drug conjugate designed to deliver a cytotoxic agent directly to the myeloid leukemia cells by engaging CD33 at the surface of the cells. In preclinical studies, the cell-killing activity of hypomethylating agents and 33A is enhanced when these two modalities are provided in combination. To date, 53 AML patients with a median age of 75 have been treated on this study with this combination. The key eligibility criteria is provided here. Generally speaking, these are older patients who have declined intensive chemotherapy or have not been candidates for intensive chemotherapy and who have CD33 expressing AML. Again, the majority of patients have CD33 expressing AML. Upon screening and enrollment, patients can receive up to 4 cycles of treatment with the combination, receiving the hypomethylating agent first for a defined course as per the specific HMA agent, followed on the last day by administration of the 33A compound. If the patients have achieved a response or deriving benefit clinically during the 4-week cycle, they can continue to receive treatment thereafter with follow-up and assessment every 3 months. During the course of the study, we determined that the combination of 33A and HMA was well tolerated. The most common adverse events were related to on-target effects of the drug, which manifested as low blood counts or cytopenias. These also included febrile neutropenias. There are few off-target non-hematologic side effects. The early mortality rate was low, 2%, 30-day mortality, and 8% 60-day mortality. Quite intriguing was the high response rate seen with the combination. 33A plus HMA therapy led to a remission rate, a composite remission rate of 71%, the majority of which were complete remissions at 41%. The median time to remission was 2 cycles. In conclusion, 33A and HMA provide a favorable balance of safety, tolerability, and activity among older patients with AML. This high remission rate in this traditionally high-risk group and difficult-to-treat population is very compelling. Response rates were higher and achieved more quickly than would be expected from historical data associated with HMA therapy alone. Overall survival data will be presented this afternoon. These are promising and continue to evolve. A phase 3 trial, randomized, placebo-controlled, of 33A plus HMA versus HMA plus placebo in older AML patients is currently enrolling. Thank you very much for your attention.
Well, thank you very much for your interesting contribution. Any questions from the journalists, please?
Hi, excuse me, Neil Osterwald with the Oncology Report and Hematology News. Could this agent be used, or have you tried it in patients with treatment-related AML?
There have, I suspect, I don't know all of the numbers off the top of my head, but I suspect over the course of its investigation as a monotherapy or in combination, patients have been treated who've had therapy-related disease. But I don't have the specific data regarding how well those patients did. There is some data that I will present later today looking specifically at other high-risk populations, such as those who have MDS-related AML or complex or high-risk karyotypes. But specifically therapy-related AML, I do not know how many patients were treated. I suspect a good number, but I do not have the data available specifically for those patients.
Okay, thank you.
I like this Trojan horse approach. So what is the response rate if you apply the antibody-drug conjugate as single agent?
Well, there is a response rate we in general have treated a very limited number of upfront patients with the single agent. So that data is probably not there. In the relapse refractory setting, the response rate as a single agent is lower. I will refer you to abstracts that were presented last year that have looked at that, but they're below 50%. Suffice it to say, the combination here is what's promising for the upfront patients among older, strategy among older patients with AML.
Do you foresee to implement this strategy in younger patients, younger fit patients with AML?
As of now, the main strategy is to look at the phase 3 trial among older patients or less fit patients. The trial will study all patients above age 18. However, it is specifically focused on those individuals who are more likely to be hypomethylating agent therapy candidates.
Right.
So those individuals who would not tolerate or would not be appropriate for aggressive induction approaches.
Right. Any further questions? Lily.
Hello, and thank you very much. Could you comment on the quality of life for patients during treatment? Are they at home or are they in hospital?
So, one of the challenges that we have as physicians treating predominantly AML is that the options we have for patients is we can give aggressive inpatient induction chemotherapy, tell them you'll be in the hospital for 30, 35 days, have a terrible quality of life, and thereafter hopefully get a remission and go home. Among older patients, this becomes even more pressing, more challenging situation. So that is one option for some patients. And traditionally, there were these hypomethylating agents where you could give them in the outpatient setting, but for whom the rate of remission was much lower. More gentle treatment, much lower response rate. This may strike a balance where you can still treat patients on the outpatient side. They can still be home for the most part, unless they become sick or have issues that require them to come to the hospital. But for the most part, be at home and be surrounded by their families during the course of their treatment. So I do speculate that there is going to be some positive impact on the quality of life for our patients if we're able to demonstrate that such a combination is promising.
So the cytostatic part, before you give you the floor, the cytostatic part of the ADC, does it have any toxicity itself because it's released from the killed cells, and like with other antibody-drug conjugates, we start to see toxicity?
It is not thought to be, because of the stable linker, it's thought that there is no release of the toxin while in circulation, and that it's only released once inside the cell. And in fact, the majority of the toxicity that's been seen on study has been on-target effects that has been demonstrated. In my experience of treating patients at my site, I have rarely seen a problem such as been seen with
great news.
prior antibiotics.
Just one quick question. Were these data presented at ASCO?
This data was not presented at ASCO.
Okay, great.
And my final question would be, you describe an 8% death rate at 60 days, and what are the causes of death? Is that melanocytopenia, septic shock, or?
We can certainly provide you that data. Majority of those, I suspect, are related to infections and other types of episodes, but I don't have that.
Okay. Well, thank you.